Hi everyone. Just wanted to provide a summary from last week. I've recorded this a bunch of times, so I apologize for sounding a little frustrated. I'm having some technical difficulties. So I just wanted to provide a brief review of a concept that I discussed in the discussion board. It is in regard to charges versus reimbursement. And I'm sure some of you saw it, but I know that the discussion boards are very large because there's so many students. So just for those that may have not seen it. So this past week we talked about charging, obviously. So we have charges. That is the concept that we were talking about. But keep in mind that charges are a set level. So charging, and when we're talking about setting charges, this is the amount that everyone is going to get charged. So I come in, I have Excellus Blue Cross and Blue Shield. That's the amount I get charged. My mom goes in, she has Medicare. She sees the same physician for the same service. She's going to get charged that same amount. Someone comes in that has no insurance, that's a self-pay patient, they're going to get charged the same amount. Everyone gets charged the same. And you may have read in the book, the reason that we charge everyone the same amount is due to the Sherman Antitrust Act. So we need to charge everyone because we don't want an antitrust violation. Everyone needs to be charged the same amount. Another reason is due to discriminatory act. We don't want to discriminate against anyone. Everyone gets charged the same. Where things start to differ is, so I have Blue Cross and Blue Shield. My mom has Medicare. Obviously, the provider is not going to get paid the same for both of those. So where the difference comes in is here's my charge. Reimbursement is down here somewhere. So there's the charge amount, and then there's the reimbursement amount. Between that charge amount and the reimbursement amount, there's a gap. That gap is what's called the contractual write-off. So the gap for Blue Cross and Blue Shield might be about this big. So here's the Medicare patient over here, here's the charge amount, here's the reimbursement amount, and the gap may be wider. For a Medicaid patient, maybe here's the charge amount and here's the reimbursement amount, because Medicaid doesn't pay very well, so that gap is very wide. So it's going to vary, but that charge is going to remain constant for all patients. It's that reimbursement amount that varies, and that contractual write-off gets bigger or smaller. Now, within your reimbursement amount at the bottom, that's where your beneficiary or your insured person's contribution comes in. So it may be a coinsurance or a deductible payment or a copay, depends on the patient. Some patients don't have to pay anything because it may be a service that's paid in full. Or it could be like Medicaid, they often don't have a copayment or a coinsurance. But some patients, like if you have a high deductible health plan, you have to pay your large deductible. But so let's say the service that you come in for costs $1,000. The charge is $1,000. But in your high deductible health plan, they have a contractual rate of $300 for that service. You don't have to pay $1,000 for that service. You only have to pay $300 for that service, and that $300 is what's going to go toward your deductible. So that's why, and I'll talk about this in a second with regard to one of our questions. That's why the lists that providers are providing with regard to lists of charges secondary to the ACA are not all that helpful because it's just a list of charges and nobody pays those charges unless you're self-pay. So what is helpful are the systems like St. Clair and some other hospitals are providing, where you actually plug in your insurance information and it will tell you what your approximate charges would be based on your insurance. So those types of systems are helpful. A list of charges, it can give you an idea. It can help you bargain shop because it can give you an idea of which hospital may be more expensive than another one, but it's not going to give you an idea really of what you're going to pay in the end, especially if you have a high deductible health plan. Because although this hospital may be more expensive than the other one, they may have really great folks in their managed care contracting arm that negotiate great rates. So it's really, I would never make a total decision based on that. I would always give a call if you're going to have a major service. and you have a high deductible health plan, I would always give a call and see if you can get some more detailed information from their billing department to find out what your ultimate responsibility would be. Okay, so good discussion this week. Interesting about how to kind of regain the faith of the public with regard to some of these types of things, such as pricing transparency tools. I think the one thing that will be helpful is if they can at least make those charging lists available online, because right now they don't have to, they just have to make it available. So I don't know why people didn't make them available online, but a lot of places don't. And a lot of it is really hospitals we kind of came up in a realm of we would never share our prices with each other due to the antitrust ramifications. So we would never share prices with one another, and now that we're expected to kind of put it out there, we're just going to make it available at our facility and not put it online. So it's kind of goes against the grain of hospital folks to just say, hey, here's all our prices. But to make it available online, I think would be one good step. But systems like what folks had shared, the St. Clair system, and there are definitely systems that you can integrate into your patient financial management system that will provide that tool. Those are great options. So really nice way to help your patients. I like those a lot. Okay, so let's go over these quiz questions, hopefully, and nothing will die, and I'll be able to get this video out to you. I've been working on this for an hour and a half. It hasn't gotten done yet, so hopefully this one will work. Okay, first question. I'm actually going to give credit for this question. There's only 2 folks that need credit, but you'll get credit for this. The question was, what does the Patient Protection and Affordable Care Act of 2010 require not-for-profit hospitals to do regarding charges? So the answer was limit charges to patients who are eligible for assistance. And what it requires not-for-profit hospitals to have a financial assistance program. So all not-for-profit hospitals have to have a financial assistance program, which will provide them with an opportunity to have a lesser charge, discounted charges, etc. And that's a requirement under the ACA. However, one of the other answers was allow patients to view a list of charges for services. So some folks chose that, obviously, because hospitals have to allow patients to view a list of charges for services. What this question was getting at is it requires all hospitals, not just not-for-profit hospitals. But the answer is not wrong. So I will give credit for that answer as well. So folks that chose that answer, I will give credit for that, and I'll go back through and do that for you. Next question. Providers set charges on the basis of blank in competition-driven charging. So the answer was what the market will bear, and what this is regarding is in this marketplace right now, so and has been for many years, charge setting is really, it's kind of a capitalistic realm. So think about the way we set charges for anything. We set charges based on what people will pay, what insurers will pay. That's how we set charges in today's world. However, when you think about it, and as we were just talking about, nobody really pays charges. Nobody pays that level. They don't pay here, they pay here. So they don't pay the charge level. They reimburse us on some contracted rate that's already set. And it's very rarely, way back in the day when I first started, 25 years ago, I worked for a third-party payer. The majority, with the exception of inpatient, the majority of our contracts were a percentage of charges. So if a provider decided they wanted to jack up their rates, our reimbursement would incrementally go up. But we learned very quickly that we needed to not negotiate those types of contracts anymore because of that reason. So really, between managed care and those types of contracts going away, and prospective payment systems, which are really setting in place bundled payments and DRGs and those types of things, we really don't see it. Kind of limits this competition driven charging. It's still there, but it's not as impactful as it would be otherwise. Okay, next question. Price driven costing is the practice of, the correct answer is cutting costs to break even with charges. So price driven costing is really a practice where you're really driving down cost so much that it actually can be harmful to your organization. So you're driving down cost, and it actually is driving it down so low that it starts to impact quality. So for folks that may have worked in healthcare organizations going back to days before we were so worried about quality of care, you may have been there at a time when we were very, very short-staffed, more short-staffed than now, very short-staffed, never brought in travelers or those types of things, but very short-staffed, didn't have enough supplies, these types of things. And that was based on oftentimes these situations where we were doing price-driven costing, driving down those costs to break even with charges. And the problem was, what we saw was that it really wasn't, it's great to drive down those costs, but it was impacting quality. So now the key is, let's be efficient in our cost. Let's make sure we have an adequate staff. Let's make sure that we're doing just-in-time supplies, so we have supplies, just what we need, but let's make sure we're providing good quality. So that's the key there. Last question. ChargeMaster enrichment ensures that, and our correct answer is, healthcare organizations are charging only for items third-party payers recognize as legitimate charges. So when we do ChargeMaster enrichment, this is when typically, well, I shouldn't say, oftentimes a large organization will bring in a ChargeMaster consultant to do this type of thing, but it can be done with in-house by a ChargeMaster coordinator, but it'll be an analysis of the ChargeMaster overall to look at, are things accurate? Are we charging for things appropriately? Are we charging for the things that are recognized as legitimate charges? But also, are we missing things that should be legitimately charged for? And then my important thing from a compliance perspective is, are we charging for things inappropriately? We want to make sure we get those out of there. And then also, just checking for coordination across the entire ChargeMaster. Are we charging appropriate charges, one department to another? Are all the codes accurate? Because the ChargeMaster is a comprehensive listing of codes across the entire, of charges and codes across the entire hospital. So every department is accounted for in there, every charge that is made out of every department in the hospital, and all of the medical codes, CPT, HCPCS, and ICD-10 codes out of all of those areas. So very important that it's accurate and comprehensive, and that we're coding for everything we should and billing for everything we should and not for things that we shouldn't. So that's the key in the ChargeMaster. So an enrichment is making sure that we're only billing for things that are recognized, not billing for things that we shouldn't be billing for. And that's the key to that. So, so that's all I've got this week. If you have any other questions, please let me know. Hopefully when I hit end on this, it'll save. And if not, I'm probably just going to skip the video this week. And I will hopefully see all of you in the discussion boards this week. Thanks so much.